Good evening, everybody. We are live here from ARIA, Concierge and Functional Medicine. Super excited to be here. It's been a really great summer, a really hot summer, but we're super excited because today we love doing podcasts and collaborations with super interesting people and great physicians in our community, and we're joined by Dr. Jim Schaefer here today. And before we get started, I'd like to do a little bit of an introduction with Dr. Schaefer. He's been a neurologist in the Vero community since 1997. He's been in private practice, but before that, he attended the University of Miami, Jackson Memorial Hospital from 1989 to 1993. He did his internship there, 1993 to 1994, and then he did his residency at the University of Florida, Shands Hospital, one of the best neurology programs in the country. And then since 1997, he's been in private practice here in Vero. And of note, in addition to that, having served thousands and thousands of patients in the community, he's actually, unbeknownst to a lot of his patients and colleagues, he's actually got over 70 trials dealing with things like multiple sclerosis, Parkinson's disease, and other various types of neurologic diseases. And so we're super honored. Dr. Felice, of course, is here. We're super honored and happy to have Dr. Jim Schaefer here with us today. So thank you so much.
Well, thanks, Fred. Great
Thank you for being here.
Congratulations on ARIA, and you guys are doing great things.
Thank you. Thank you.
Really super psyched.
For those of us that follow the podcast and, of course, our patients, those of us that know us know that Felice and I are super passionate about prevention, and as a consequence, we're very, very passionate about things like identifying and then treating insulin resistance, and making sure that patients are as metabolically healthy as possible. And so, for those of us that kind of follow this and have certainly worked with Felice and I over the last probably 5 years, 10 years, certainly the last 5 years, we're starting to draw a greater and greater correlation between Alzheimer's disease and insulin resistance. In fact, you hear a lot of people in the news media and even in conventional medicine referring to Alzheimer's disease as type 3 diabetes. And I think there's more and more nuance being developed with this and more understanding. I think that of late, a lot of us are kind of looking at it as not even so much type 3 diabetes, but advanced insulin resistance or glucose dysregulation of the neurons, which are the cells in the brain that make up a big portion of the brain. But so we're going to talk about all these things. Primarily, we're going to talk about some things as it pertains to Alzheimer's. But before we get involved with all that, one of the things that I think my patients are confused about, and I think a lot of doctors that are outside the neurology world are sometimes can get confused about, is the diagnosis. Like, how do we establish the diagnosis? It almost seems like there's a different criteria in Europe as there is in the United States. So how do we establish the diagnosis?
So that's a really important point. And I think to your point regarding Alzheimer's being a part of insulin resistance and the type 3 diabetes, and I look at Alzheimer's, it's a biological disease process. It's not just about tau and about amyloid. It's about multiple things. And again, like you're talking about insulin resistance. But diagnosis is the first piece we have to decide when we're doing this. The patients that come in, I get a lot of people come in and, hey, doc, my memory's going bad. I'm missing words. I'm forgetting words. I'm having trouble doing things. And they worry. First thing they worry about is Alzheimer's. I mean, it's the most common form of dementia in the U.S., right? And so we have to start with this history piece. What's the history, which is the super most important piece here. So patients come in, they complain of having memory difficulties, they're having trouble word finding problems. And so, nowadays with the biological markers, and we have PET scanning, we have all these testing we can do, their patients are seeing their docs and they're coming in my office. I got my APOE test and I got my tau test and they're abnormal. I have Alzheimer's. Back up.
You're right.
Yeah. So I really got to back up on that and say, let's start way back in the beginning here, because as I said, and as you know too, this process it begins decades before manifesting clinical symptoms. And that's one of the limitations we have now, is that all these trials and the studies that have been done really are at onset, right? And then some identifiable marker on testing that they can do is say, okay, you have MCI, mild cognitive impairment, and now you're part of the trial. But the reality is they've had this disease process for probably 10, 15, 20 years. And that's where it's getting pushed. But getting back to your issue about diagnosis and seeing patients. So we see them, get their history, how are they functioning. We will first determine, and the most important piece of neurology of anything is history. Okay, let's talk about your cognitive problem. Dementia. So I have dementia, I have Alzheimer's. What's the difference? Dementia is a symptom. Alzheimer's is a disease. So dementia. Do you have problems, cognitive problems? Are they affecting yourself socially, personally, or professionally? If you're not being impacted necessarily by your cognitive function in some realm, by definition, you may not meet dementia, which again, may be a high threshold. It may be early elements of dementia there that we can't detect yet. But the bottom line is we find out where in your sphere is this cognitive problem causing difficulties. Once we determine you have cognitive issues, maybe outside the range of normal, then we will get an MRI to make sure you don't have hardening of the arteries, vascular disease. Huge part of this is vascular component. Let's determine you have a brain tumor. You don't have all these other things going on. EEG, cortical function of the brain is very important. We look at the EEG. We do some lab testing, which may be not necessarily markers, but let's look at their glucose markers. Let's look at thyroid function. Let's look at methylmalonic acid. Look at some of these things, and then cognitive tests. We'll do a baseline of mini mental status. We'll do a Boston naming test, which is language. The most sensitive part of early Alzheimer's is actually language. You can begin to lose language early on in the disease. Word finding, anomias, something that can be very early detection.
I think I've had it since age 8.
I know. I tell people about
since age 8. Yeah.
So oh my God, I can't find words. I can't. So don't sweat it. But I'm saying, but we look at language and we look at the processing, those three things. And so get them out, get them back in the office. And we look at those high-level markers. Is something sticking up here in the flag? If something does, we head down that algorithm path. Is it markers? We'll talk about markers later. Was it markers? Is it PET imaging? Where else do we go from there? So it's a very complex diagnosis, if you will. And even today, we're getting better. Probably in the upper 80s, low 90s, and percent of being able to diagnose really affirmatively a diagnosis of Alzheimer's. Much better than 50-50 chance 20 years ago. Yeah. Patients tell you, my mom had Alzheimer's, my dad had Alzheimer's when they died 25 years ago. Well, they weren't very good at diagnosing it.
Right. We weren't looking at APOE and tau protein and amyloid-beta 42.
Who was diagnosed in
2000.
2000. Yep. And I was just listening to a podcast where they said if your loved one was diagnosed before 2006, 2007, then you didn't know for sure they had Alzheimer's. Whereas now it's more predictive.
We're getting more predictive. Yeah, we're much. But back then that's hard. And then not everybody has dementia. That's Alzheimer type, right? There's all variations. It's senile dementia, Alzheimer type. Some of the baseline pathophysiology falls in this amyloid. We'll talk about this later. Some of these other proteins, but the bottom line, the diagnosis is complex, and it takes many factors to make the diagnosis.
Thank you. So, and that provides a lot of clarity. I think a lot of us that deal with patients in the primary care setting, I'm both in the primary care and in the OR setting, tend to have a little bit of confusion as far as how we establish that diagnosis. So the fact that you're telling us it's pretty complex, makes us feel a little bit better. And I think certainly we're making strides. You've mentioned a couple of things that I want to unpack. And I think one of the things that you mentioned is that the disease process, when we talk a lot about vascular disease, we talk a lot about vascular plaque. We talk a lot about, insulin resistance and insulin resistance being upstream from a lot of non-communicable diseases. One of the things we always stress is that if you are really interested in preventing vascular plaque, the best time to do it is, probably when you're a young adult or even earlier, to start understanding risk factors from a lifestyle standpoint, from a lipidomic standpoint, genetic standpoint, et cetera, et cetera. So Alzheimer's is, I think, kind of the same way. This is a disease process that develops over decades. And whenever I'm listening to people talk about medication intervention and all of these kinds of things or establishing the diagnosis, having spent a lot of time in the OR, having spent a lot of time in the ICU and taking care of hip fractures and dealing with, talking with families and having to make those end-of-life decisions, it always dawns on me, regardless if you're 92 or 71 or whatever, I would rather just not have Alzheimer's. And so the question is, how do we prevent it? The question to me is like, what are some things that we can teach our patients now to prevent it? Because I'd rather, so in your mind, are there things, if we're sitting down, let's say we sit down with a patient who comes in and said, hey, we're interested in longevity. I'm 45 years old and I surf right now, and I want to surf at a high level when I'm 85. And I have two parents that both had Alzheimer's disease and were diagnosed at the age of 75 and were non-smokers. What would you say to that patient? What are some things that we can do right now to say, from a lifestyle standpoint, from a genetic standpoint, from maybe a lipidomic standpoint, to start preventing or thinking about prevention down the line?
Yeah. So again, those predictors of preventing, we all want to prevent, right? So I think I would call it more of a worrying of, we want to reduce the risk, right? So we're going to reduce the risk a lot. And so what you're tapping into is very key. From my perspective, if 45-year-old comes in, 50-year-old comes in, they're like, they've got some early cognitive issues. They say, well, my parents had Alzheimer's disease. I'm like, okay, well, first off, it's not necessarily a genetic disease, right? You carry genetic risk, and that genetic risk actually falls basically into the metabolism of your body. It really comes back into what you guys are doing with your genetic profile, your lipid profile, your glucose metabolism, your insulin resistance. All those things play a role, and those are the factors that really, as a primary care, and what you all are doing with ARIA is you're tagging it on that end. Because we really don't know the downstream parts of this, but we know that there's multiple components that play a role. Again, Alzheimer's is a biological process. It's not just simple, it's not a dementia. It's a disease process of many things. So for these patients, of course, it's usual stuff. He's an active guy, exercises, right? Sounds like a dumb thing, but exercise is key. Aerobic exercise, everybody says, oh, everyone says exercise. Well, exercise and diet. Again, very, very sort of cliche, but there's no doubt that what you put in the system, what you put in this body is what comes out. The guys in the Tour de France this year, they're finding out that really what the key with these guys are doing, they're learning how to eat. They're the same as they were 30 years ago with cycling, but they're learning how to eat now. And that's the whole process. So that's a big factor. The bad things, alcohol is not so good. Obviously, smoking is not good for you, the basic stuff. Blood pressure, huge. Blood pressure is a monster thing. In this country, blood pressure alone could reduce our strokes by 50% if we just watch blood pressure. We don't do such a good job at that. It's all basic things. But then getting deep into this more metabolism of our systems is really where at the end of the day, we're going to find that's where we're going to pick up on this stuff early markers. Hopefully we get to age people in their 30s and 40s, and we can begin to find out you are that person heading down the path with high predictability at 60 to develop this disease process and begin to treat it then. And that's really, prevention's a piece, but treatment's moving that way too. That's where we hope to get someday.
Amen. And I think that for those of us that have, taken care of these patients, I think I'm always I think we all put ourselves in our patient's position, and I'm always kind of like, geez, I don't want to be in this position. I don't want to ever experience, really any type of dementia, specifically Alzheimer's dementia. You had mentioned a little bit before when a patient comes in, you had mentioned a little bit about, vascular dementia, multi-infarct dementia. Felice and I have looked a lot in this, and we've kind of, studied, we have Lewy body dementia, we have multi-infarct dementia, we have Parkinson's disease, we have Alzheimer's. It seems as though there tends to be some overlap. And we, of course, could probably have a podcast on just those four diseases and talk for 12 hours, but can you talk a little bit about, what your thoughts are, how often there are overlaps with those four things? Is there sort of this unified molecular theory behind all of these things where it's kind of similar, and maybe Lewy body presents in one way or Alzheimer's, but maybe underlying this is some type of very similar abnormal metabolic process or, inflammatory process? But I think just for the sake of maybe brevity and high yield, how much overlap is there, and how do you navigate that as a neurologist?
So again, the neurodegenerative disorders. So in neurology, I have the great privilege of being involved in all these degenerative processes, right? So I don't get to fix things and watch it get better. I'm basically holding hands the whole way through. So this is the fate of a neurologist. But so in that same vein, these neurodegenerative diseases you mentioned, Parkinson's, Alzheimer's, Lewy body, multi-infarct, frontotemporal dementias. ALS, these motor neuron diseases, the dementia of Guam, all these they're all sort of lumped into this group, right? There's many types of Parkinson's. There's SDAT is senile dementia, Alzheimer type. Where and when the plaques place themselves in the brain, in their density and their location determines the manifestation of the disease process. So you have your primary progressive aphasia Alzheimer patient, you have your congophilic angiopathy Alzheimer patient, you have your standard Alzheimer patient, you have all these people present clinically differently, but it's where and how these plaques are forming. Now, the mechanism, as you said, intracellular, our cells are all the same. They all, you said we could talk about mitochondria, we could talk about ribosomes, we could talk about nuclei, we could talk about everything you want. But at the end of the day, the processes are pretty darn similar in all of these cells. And they may have different environments, but those mechanisms are the same. That's where, again, getting to this basic, as you mentioned, the metabolism piece, is very, very, very important. The differentiation comes about really by their clinical manifestation, and of course pathology as well.
I love it. Talk a little bit. One of the things that we have, it seems like a greater awareness is even amongst patients with, of course, the Peter Attias, the Hubermans, Mark Hyman, even going back a couple of decades in the functional space, is the APOE4. And I feel like you get a lot of patients asking us now about, hey, can you check for, do I have a genetic predisposition to Alzheimer's, and can you check this and that? And for us, for our practice, one of the basic things we can do with Quest is check their APOE status. So for those of us, for the listeners, APOE is essentially a receptor site that exists on different types of, I'm going to use a big word here, lipoproteins. So for instance, the LDL particle is a lipoprotein. The quote bad cholesterol HDL particle is a lipoprotein, and we can all have either a 2, a 3, or a 4 ApoB or ApoE, which is a receptor site on the outside of that lipoparticle from either mom or from dad. And if you have either a 3 and a 4, a 2 and a 4, or a 4 and a 4, then you might have a genetic predisposition to Alzheimer's. Can you talk a little bit about that? Maybe hit on the pathophysiology a little bit, what it means in the brain, and then when you have patients that, let's say they're presenting with some mild cognitive dysfunction, and you see that they're 3-4 or 4-4, or maybe they know they have a genetic predisposition, they're younger. How might you intervene? What are the things that you talk about? How do you educate patients?
Well, as you mentioned, the APOE4, you can have a single haplotype of it, or you can be homozygote or heterozygote for it. Have 1 or 2 copies of it. There's 2, 3, and 4, as you mentioned. The 4 is one we have most interest in. As you know, that trigger or that receptor site, by having that 4, it triggers a whole cascade of inflammatory, cytotoxic events that occur in cells. So, and that's on the vascular side of things. So, from my perspective, from a treatment site, we don't necessarily use APO too much. I use it mostly in my risk stratification for patients who may receive the new generation therapies. We'll talk about that in a minute, I know. But APO4 is very important there because as we have 1 copy or 2 copies, a single copy of the A4 or the E4 will increase your risk of having Alzheimer's or developing Alzheimer's about 3 to 5 times in a lifetime. Double, it's about 12 to 15 times the increase. So you're going to see your risk. Now, it's not a Mendelian gene, right? So it's not something you pass on like we do.
Destiny necessarily.
No, it's not. I'm going to be very careful with APO testing because I got the APO gene, I'm going to get this. No, you're not. It's a marker. And really more so, it's a marker for us to determine potential risk for adverse side effects of the new generation therapies we're using. So again, but the background that has that APOE gene is it all follows back onto metabolism and lipometabolism and everything else. So it's a marker from that perspective, but mostly we're using it as a risk stratification for treatment.
Love it. Thank you so much for that clarification. Now, you mentioned something else that I thought, and this is highly relevant, I think, in our practice. One of the things that we strive for is sort of demonetizing medicine in a way, as far as I think a lot of patients get frustrated in that, you tend to have the different subspecialists looking over here. Maybe the cardiologist is looking over here and the gastroenterologist is looking over here. One of the things that we always strive to do is sort of bringing everything together and treating the full patient. You mentioned risk. You mentioned 3-4, APOE 3-4. You mentioned 4-4, and I think you said 3-4. You know, your risk for Alzheimer's is anywhere from, and we use 3-3 as sort of the baseline. That's about 70% of the population, if I'm not mistaken. And there's really no increased risk if you're APOE 3-3. So if you go 3-4 and you're a male, you're about 2, maybe 3 times greater chance. If you're female, maybe 4 times greater chance. Same way APOE 4-4, if you're male, about 10 times greater chance. If you're female, maybe about 15. So there is an increased incidence, or there is an increased risk of Alzheimer's just by being female sex. Is that correct?
Yeah, we see that clinically, and it's
been proven. So, and obviously here of late, we talk a lot about this. You know, Marty McCary removed the black box warning with estrogen. I think we had the controversial study that came out in 2002 with the Women's Health Initiative talking about the increased incidence in breast cancer. And Felice and I have talked ad infinitum on previous podcasts about that study. But one of the things that I find interesting, particularly if you look at a guy by the name of Dr. Avron Blooming, the book Estrogen Matters, certainly there are other doctors that have talked about this, is the potential beneficial effects of estrogen as it pertains to the brain. And it particularly as you look at women with a greater incidence and greater chance of developing Alzheimer's, particularly if they've got a genetic predisposition. Mm-hmm. Is that something that you're starting to explore more and more in your practice?
Yeah, well, clinically we see that, right? And I think you can even go back to the earlier studies when you're looking at women in heart disease. Right? So 30 years ago, women were the unknown person that we never thought about having a heart attack at 40 or 50. So they were the silent people having heart attacks and dying of strokes, and we weren't sure what was going on. So they always were never really thought about in a high level sense, otherwise males. So what we've obviously come to find is that women at some point in time have a lower risk. I have to go back to heart disease and stroke disease, which goes back to vascular, which goes back to this whole process of APOE, goes back to the whole process of the blood vessels in the brain, and goes back to plaque. It all figures together, right? Mm-hmm. So that being said, so as women go through menopause, they lose that protective effect of estrogen. So what happens? They're behind the game a little bit about it. Their prevalence of incidence of stroke and vascular disease. They catch up real quick, and they even surpass.
Yep.
So we see it across many disease states, and we certainly see it in Parkinson's, and Alzheimer's. An interesting thing that I've clinically experienced, and there's some in the literature too, is that women get it's a more aggressive disease, and it seems to be more progressive and more difficult to manage in men. It seems to be a slower process. I think that's just a clinical experience, but. Alzheimer's, Parkinson's, and ALS. I mean, this is something I've seen over the years.
Interesting.
And I don't know where that comes from, but I've seen that in across the sexes, male, female.
And so there's this gender gap, right, with Alzheimer's, and the argument prior, I think it's starting to shift. You tell me, but the argument prior was that women live longer, and that was the reason. But I think they're moving away from that. I've heard that argument so many times that's why they get Alzheimer's 2 times. It's just because they live longer. So you have a prevalence. It looks like they get it 2 times.
There's prevalence and there's incidence. So it's there's rate of diagnosis, and there's also existing at any particular time.
Is there a consensus?
I think it's this consensus now. I think it's unequivocal that women corrected for age get Alzheimer's at a greater incidence than men.
Yes.
And this is really interesting. If you do a deep dive and you do a lit search and you actually start looking at estrogen, there's actually really good data on estrogen actually lowering LDL particle number, lowering ApoB, which we've talked a lot about. ApoB is the receptor, the part of the LDL particle that binds the LDL receptor, and it's also on the outside of VLDL, IDL, and then LP(a). All 4 of those ApoB particles can move into the vascular intima and become oxidized. So estrogen will lower ApoB, it'll lower LDL particle number, it'll lower highly sensitive CRP, which is a marker of inflammation, and it actually upregulates something called nitric oxide synthase, which is what both men and women need in their endothelial cells to make nitric oxide. And we know nitric oxide is is very, very vascular protective. It's what men need to keep a low blood pressure, to keep and maintain an erection. It's what women need to enjoy sexual intercourse and not have vaginal dryness and all those kinds of things. For those of us that are familiar with the podcast, they know that my conventionally, I'm an anesthesiologist, and I've come to the functional space over the last probably 5 to 6 years. My wife has been in this space for a much, much longer time. And I'd like to ask this question to Felice, because I've seen it a little bit. I know this has been her experience. Talk about when you have patients who are moving through menopause, female patients, and they talk about how all of a sudden they have brain fog.
Oh, yeah.
And they really, really struggle. It's like all of a sudden they can't remember things, and they struggle with maybe remembering, things that they always remembered in the past, or, setting their keys down, things that, guys typically do since they're 5 years old, all of a sudden they're doing, right? And so talk about your experience with that. And then when you actually optimize their estrogen, you optimize specifically their estrogen, but of course pair that with the progesterone, maybe a little bit of testosterone. What's been your experience with
My
that?
experience has been, I've experienced it myself. So I can tell you, I knew exactly when I went through menopause. I mean, I remember literally the week. I was like, I'm in menopause. I knew it. And yeah, you experience all those things even up until before truly going through menopause. And it's like going over a cliff. It's like all of a sudden one day your ovaries are making hormones, and truly they go up and down, and then one day they just stop. They truly just stop. And so my experience has been, even in perimenopause, as they're leading up, they start to have this brain fog, and they get depressed, and they start getting trouble with losing body fat or belly fat, and they're emotionally labile, and so they're struggling with that. And so I really don't wait to start. I mean, obviously, if you're a patient of ours, we are lab happy. I mean, we are looking at your labs. We are on top of you. So we don't do things just cavalier. We are really, really watching laboratory levels and starting earlier, and really kind of evaluating your hormones even earlier. And when I say earlier, I'm talking like late 30s, early 40s, when you start having menopausal symptoms, like losing sleep, any of those things I just mentioned. You should be starting to look at those lab levels, and you should be starting to replace them. And we always use natural hormones here. We don't use any synthetic hormones. So we use bioidentical, which you can get at a regular pharmacy. Most people are confused by that. They're like, no, you can only get them at compounding pharmacies. Not true. An estrogen patch is natural. It's completely natural estrogen. Progesterone is sold at CVS, Walgreens. So in any event, if that answers your question, I err on the side of starting early. And once you hear those symptoms, you know what you're dealing with. It's very easy to pick up on it.
And we talk about the 10-year window between menopause and starting. Certainly, that's when the benefit to risk ratio is highest, is within the first 10 years of menopause. After 10 years, there's some thought that potentially, if there is plaque, particularly in the coronaries, within that first year of starting estrogen, the benefit to risk ratio may not be as clear. Ultimately, I think the estrogen is good for the plaque, but there is some thought that there might be an increased incidence of making that plaque more unstable in the first year. But again, these are all decisions that we weigh in a very, very precise benefit to risk ratio. But even today, I had a patient, and it was amazing. I mean, she's right at about 10 years post menopause, and had been experiencing all the same things. I think she was on like 15 of tirzepatide, which that's a whole nother discussion, but that's a gigantic dose of tirzepatide. And for the listeners, that those are the GLP-1 agonists, or the GLP-1 peptides that we're using to treat type 2 diabetes, and they're now being used for medical weight loss. And 15 is a gigantic dose. And so she was having trouble losing weight. She had brain fog. She had gastrointestinal disturbances, all these kinds of things. And we started her on just a very, very moderate dose of estrogen, bioidentical estrogen, progesterone, and testosterone. She came back, her labs looked beautiful, and she said, "Oh, I feel great. I've got energy. I feel like I'm losing weight. I've got more motivation." She still works. She owns a company, and her libido had improved. And so it was just really, really interesting to see that. One of the things that we talk a lot about, and again, is metabolic health. We talk a lot about APOE4, and it's when we say metabolic health, and I'm going to try to make this as simple as possible for the audience, and we say insulin resistance. Okay, the reason that we stress insulin resistance is because we feel in our practice that insulin resistance is upstream from not just type 2 diabetes. We know that over 50% of everybody that gets diagnosed with type 2 diabetes has plaque in their coronary. If you go to to coronary arteries. If you go to PubMed and you type in insulin resistance and cardiovascular disease, you'll find about 42,000 entries. So cardiovascular disease, stroke, all forms of vascular disease, type 2 diabetes, fatty liver, erectile dysfunction. We're talking about dementia right here. It probably, if it doesn't cause cancer, it certainly provides a very favorable metabolic milieu for cancer to grow, insulin resistance. And what that means is it's the cell's inappropriate response to insulin signaling. So the way the cell works is insulin hits the receptor, and then what that causes ultimately is there's something called a GLUT4 transporter, but that transporter is like a little tube. It moves to the surface of the cell, and then glucose moves from the outside of the cell to the inside of the cell, and then the cell uses glucose ultimately to make energy. Outside of what's called the mitochondria, it performs a process called glycolysis, and then inside the mitochondria, you have a process called, another big word, oxidative phosphorylation, and ultimately you make ATP, which is the cell's form of energy. So we know with Alzheimer's that the mitochondria doesn't work very well. We also know that APOE actually predisposes to insulin resistance. And so it just kind of underscores the point that's so very important. We say, oh, there's all these cool things that we're doing, hormone replacement and peptides and, the longevity center and all these things. But like Dr. Schaefer's saying, he's been in practice here since 1997, diet and exercise. How are you moving? What are you putting into your body? How you thinking? How you sleeping? Lifestyle, diet, and exercise. So very important, foundational to human health. It's neglected. It gets ignored. It needs to be talked about. It needs to be talked about in detail. Doctors need to be providing patients with very specific, we hate the word diet, but lifestyle with how you eat.
And also social interaction.
So
important, right?
That's what a great question.
And I think the part of it when I was, I was in the sphere for a couple of years, 5 years. I was, the owner of Mind Body here in Vero. And so I had a third prong to the approach. I called it a whole, I don't want to call it holistic, like HOL, I call it holistic health, WHO holistic. So we have, you have evidence-based medicine, right? So you have your Western medicine, evidence-based medicine, very important. And it's still, it's a basis for how we practice Western medicine. Yeah. And then we have the realm of functional medicine, which is what we're talking about here tonight, and very, very important. It's that whole other side, the preventative side, the proactive side, the interactive side of things. And then we have, in my mind, we have this mindful health, right? So, the brain is very important. It's where you live, right? So this whole piece is big on mindfulness and all those awareness pieces of the mind. So you have three components. If you can capture in all three of those in your day-to-day health, lifestyle, mindful health, functional health, and good old see your doctor, get your blood pressure checked, watch your glucose. I mean, sounds straightforward, but that's probably one of the most basic things that we could possibly do and be doing, which we're all doing. So all those things I think are if you ask me, that's sort of that holistic. Yeah. WHO, holistic health.
Love it.
To me, it's holistic. It's a comprehensive model. So we need all of this. We need all of this to be a team to get this all to work for the patient.
It's so often, I think you can hear Felice and I both talking from the rooms, talking to patients. And, as a patient comes in, they say, hey, I want, MOTC and SS31, and I want to go up on my testosterone and all these things. And all those things may be great, and those may be the right moves, but I probably tell a patient on a daily basis, a good example is the GLP. We're looking at the GLPs as far as they may actually be protective or preventative for Alzheimer's. But that being said, if you're on 15 of a GLP, which is 5 times the starting dose, what can happen is you can actually lose more muscle than fat. You can lose more bone density than fat. You actually become metabolically more dysfunctional than when you started the medication. And additionally, you can have down regulation of all your intrinsic GLP-1 receptors to where they're not actually even working. So you need more and more of the medication to achieve the same effect. And it's all because you haven't changed anything about your lifestyle. And so the issue is that if you don't change that lifestyle and you're on the GLP, it's kind of like throwing the deck chair off the Titanic. Conversely, if let's say that you're a man and you are doing all the things, you're engaging in functional resistance training, you're eating a Whole30, low insulin recruiting, low inflammation diet, and you are low testosterone, and we replace it in a responsible way, well, that becomes a great thing. But conversely, if you're not engaging in any of those lifestyles, it's not a good thing at all. We just really, what at the core of, I think, what all three of us are talking about is prevention. So let's get a little more complicated. I know that we mostly speak to a lay audience, but I want to ask you a little bit about this, Jim, and I think that it's important to kind of understand this. Within the brain, there are a couple things that we look at when we're considering Alzheimer's. We look at tau proteins, we look at amyloid-beta plaques, and we look at neurofibrillary tangles. What I'd like you to do is maybe in a as lay as possible, explain what these are, and then maybe talk about where these things are located, and are there some of these that are correlate much more closely with clinical signs, and are some of these, of these three, for instance, amyloid beta plaque, might you have amyloid beta plaque without clinical symptoms, and then maybe you can have clinical symptoms without amyloid beta plaque? And I know it's a long question, but we can maybe start with
a lot of stuff there.
Those three. There's a lot of stuff, and I apologize.
language.
Go back to the beginning.
Yeah.
So the high level of this is that talk about these markers, and so and then what are they? So in a very high level of basic pathophysiology, you have your beta amyloid plaques. You have this APOE, amyloid 40, amyloid 42. These are the two major amyloids, right? So it's that ratio we look at is one component. So when that protein's cleaved, when it is formed, it has a 42 chain peptide, or it's a 40. It's 42 or 40. The ratio is a certain level in the brain is considered normal. We look at that ratio. That's one piece. That's mostly our amyloid is mostly an extracellular, meaning it's sort of it's outside of a neuronal cell. It's an extracellular component of the disease process. And that triggers. Go ahead.
And I don't want you to cut you off, for the sake of all of us in the primary care setting and outside of neurology, it is a little confusing.
Yes.
Because the amyloid 42 is higher risk, correct? Yeah. So what happens is we draw it in the serum, but if we have a low serum, 42 to 40, that's in the serum, that's actually high risk, because that's telling you the brain is holding on to more 4240.
That's correct. That it's inside the neurons?
No.
No?
It's
Okay.
extracellular.
It's extracellular,
yes.
but the brain's holding on to it, so you have less in the serum. So you have a lower number, and so I'm always it's one thing that I've really struggled to understand is like, the 42 to 40 on the Quest test is low, and I'm like, wait a minute, I thought 42 was bad. But they say, oh no, this is in the red, and then I have to do the deep. I'm like, the brain holds on. Now, does that understand? I know it's a very rudimentary understanding.
But that's basically what we're looking at.
Okay.
Basically, it's an inference what the brain's holding on to the amyloid in the brain.
Copy that.
So we're depositing. Even PET scans are saying your brain's got more amyloid than it should, because these are normal. These proteins occur in everybody. That's what the problem with some of these tests is, that we get these amyloid, we get the tau, and we'll talk about that in a moment, and we get these tests and they're abnormal, and the patient comes in and goes, I got Alzheimer's. And I say, well, okay, maybe not. Let's step back a little bit here. So the amyloid, as I mentioned, is that protein that's outside of the primary building block of the brain, which is neuron, which is the astrocyte in the brain. Microglia, astrocytes, several types of cells. The tau is more of an intracellular protein. It's the intracellular component of this abnormal pathophysiological process that occurs in the brain. And there's two basic guides of that. There's 217 and the 181. The 217 is we see that it's actually more of an earlier predictor of developing disease downstream. We're seeing that come in a very early stage. We look at the graphs and studies. You look at we're drawing these labs on people that are asymptomatic otherwise in the trials. You go back 10 years before symptom onset, and you're picking up elevations at 217. You're picking up elevations at 181. So that's where the science is moving right now. We're trying to move backwards here and try to understand those predictive findings early on. That's why drawing them early, right now we can't make good predictions about it because we don't have data that tells us where it's going. We have data, in the trials now when patients develop symptoms. They're abnormal MSE, abnormal Boston naming test, abnormal. They're abnormal. By the time you're abnormal, you're way down the road, right? So we're even now we're treating with these new drugs, the monoclonals. We'll talk about that for a minute too. we're treating, and the good thing is we're treating. We have nothing in the past that could treat this disease. Now we have a way to manage it. I could talk about that for a second, but we're already down the pathway here, and but we're making inroads. But the goal over time is going to be to push that window back to the 35, 40-year-old, hit them. And there's in trials now. There's vaccinations in trial right now. There's a tau amyloid combination vaccine in trial.
Wow.
Let's give you a tau amyloid vax, and we're gonna prevent this.
Wow.
Absolutely awesome. And then there is, as a corollary to that, the varicella vaccination. Am I correct in that? Is it the varicella vaccination that there's a reduced incidence
Just
of
hearing about
Alzheimer's,
that too.
or what?
Yeah, they're. I don't know the exact trial, but I've seen it out there and some of this.
Okay.
But we know that again, it all comes. It's this immune process, right? So these monoclonal antibodies we're using in autoimmune. We're using immune therapy to treat this.
Correct.
Right now.
Right. So I want to get to the monoclonal antibodies because I think they're really, really interesting. I love what you said, though, is that we're trying to push this back, and the goal ultimately is to identify, lifestyle risk factors, identify genetic risk factors way before the disease ever develops, so that people can basically live without this disease. And again, we talk about all the time, not just about lifespan, we talk about health span. We say, hey, we want you to be, if you like to surf now at the age of 45, we want you to be able to surf at the age of 100. We don't dictate when the good Lord calls you home, but if we're doing our job, we make you functional all the way until that happens. And I think medicine is moving in that direction.
We can learn from the blue zones too. You look at some of the blue zones in the world, and we're not seeing some of these diseases. And you look at their lifestyle and look at their diet, and that gives you proof in the pudding right there.
One of the things that I'm kind of fascinated with, and I think that they're probably with the advance of AI and a lot of these things, is we can actually look at places like Sardinia and look at places like Okinawa, places like Costa Rica, some of these blue zones, and say, hey, what percentage of the APOE 3/4s there develop Alzheimer's? What percentage of the 4/4s there develop Alzheimer's? Are there a greater percentage of 4/4s there that are never having any cognitive dysfunction at the age of 90? I mean, I personally, it's interesting. I lived in Okinawa. I was active duty, as we're going to talk about all your stuff you do with SEALs and our veterans and what, which is incredible work. But I was a general medical officer with the Marines way before I knew a single little thing about anything longevity or functional medicine. And I can remember being out in town in Okinawa, and this is 20 years ago, and it just dawned on me. I'm sitting and I see, some old Okinawan guy, looks like he's about 95 years old, drink like 27 sakis and eating his sushi and his seaweed, and he gets up from the table like he's got no osteoarthritis, no pain whatsoever, and just walks straight out. And I'm looking over and I'm like, geez, all of my ancestors who were that age, it took them like 25 minutes to just get up from the table, Yeah. And I remember having that thought. And of course, if you fly onto the island, if you fly in from the south, which most of the time you're landing, the flight pattern is from the south. The island is about 25 by 75 miles, 25 miles wide, about 75 miles long. And along the south end of the island, you'll see in the ocean all of these different, what almost appear to be fields. And then you see boats lining these fields, and you see one guy on the boat with what we would call here in Vero Beach a hookah, which is just an extension, an oxygen tank, and then a guy down diving, and he's got a tube, and they're harvesting a plant. And it turns out it's a seaweed, and this seaweed that's ubiquitous on the island is a superfood. It has I don't remember exactly, but it has all kinds of antioxidants and things. And so, but I don't think that tells the full story. I certainly think there's omega-3, tons and tons of omega-3. I think within a lot of these cultures, specifically in Okinawa, there's a gigantic emphasis on taking care and respect for the older generations, which I think is a part of our culture that we've probably lost. And I think that there's no you don't see nearly as much social media. We're not sitting, watching whatever, Instagram or news or whatever, and denigrating those who aren't like us or disagree. There's family is incredibly important. And so you see that. And then, with folks, there are cultural generational things where their hands are in the dirt, a lot of martial arts, a lot of movement, walking up and down hills. and shockingly, it translates into longevity. I really think that
No fast food.
no fast food, absolutely, and
they walk everywhere.
They walk
or
everywhere.
ride a bike. Or ride a bike.
And it's like in the United States and even in a lot of places in the West, you see diets are ubiquitous and you see gyms are ubiquitous and chronic disease is ubiquitous. So there's a disconnect. And this is why we hate the word diet. I like to lift weights. I like doing CrossFit. Folks that don't like doing that, I don't force you to do that. Our job as physicians is to come up alongside you and help you build out those lifestyles that are going to lead to longevity. And so, and it's not just Alzheimer's, it's literally every chronic disease can be traced to, these lifestyle issues, So one of the questions that I wanted to ask is that it seems to me that you have, I think of the stat I heard the other day is 44% of everybody over 90 has amyloid-beta plaque identified on a PET scan, but not 44% of everybody over 90 has Alzheimer's disease. I think the number is like 30% over 80. And so there is this sort of disconnect between the amyloid-beta plaque seen on imaging in clinical Alzheimer's. Conversely, it seems that tau protein is far more associated with, if you see it, far more associated with clinical signs and symptoms. Is that an accurate assessment? And if it's not accurate, tell us why. If it is, elaborate a little bit more on that.
So you mentioned as we get older, the burden of plaque goes up over time. So patients over the age of 90 got a significant amount of plaque burden. So again, this whole idea about amyloid being something that's a boogeyman, it's really not. It's about when it occurs at an earlier stage in life and where it occurs, the density, where it applies in the brain. That's what makes the clinical symptoms of dementia and Alzheimer's. But we're all developing these plaques. So over age of 90, the patients come in and they're like, I'm getting a little this and that. Well, you're going to be. You've got this going on. In combination, we'll see patients come in, they've got their blood work done, and the amyloid ratio is low. Tau levels look fine. Their testing it looks pretty good. They're not even MCI. They're doing good. We don't respond to that. We're like, okay, we'll keep an eye. But now we've got you on our radar, which is great. I say we're going to follow closely here, but we monitor those things. So yes, we see high 217, high 181, low ratio. A guy was, a high functioning attorney for his entire career, and he's not scoring where he needs to score on a score. He's your bingo. He's your guy. You got to really talk seriously about getting started on one of these new therapies. And new therapies, if I can digress into that for a minute.
Absolutely. Yeah.
So I think because it's a real good progression. So again, in my office now, coming in, they all want to go on the drug. I want that drug, Alzheimer's drug, to cure me. Well, A, there's no cure. Right. So everybody knows that. We're not curing this. B, these are first-generation therapies, which are amazing because up to 3 or 4 years ago, we had no drug that treated the pathophysiology of Alzheimer's. We had symptomatic drugs, Aricept, Epizil, galantamine, Exelon. We have drugs that treat symptoms, but no drug that treated the pathology of Alzheimer's.
And before you mentioned, broadly speaking, these two drugs fell into categories: cholinesterase inhibitors and then NMDA receptor antagonists.
Those are the two, right? Basically,
and now what we're talking about are monoclonal antibodies. Specifically remove amyloid beta plaque.
They're targeted to the amyloid, to the protein, the amyloid proteins, the epitopes of the protein. And there are two products. Basically, Ford and Chevy. They're both monoclonal antibodies to the amyloid protein. That being said, as we go approach this with patients, there's a narrow. We've been very lucky. I've got almost a couple hundred patients now that are on these therapies right now. So we're very, 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 very discerning on who these patients are, because in the real world out there, everybody's going, you have Alzheimer's, go on the drug. Well, it isn't. It's quite that simple.
Right.
You got to number one. It's all about patient selection, right? We know that about everything you do, as you mentioned before. You can't come in and dictate what they want to do. You have to look at everything in this patient and how you decide if they're going to be a treatment person. So, age, 85 and up, you're out of the box. You're not going to be a candidate because the risk of ARIA, which is amyloid-related imaging abnormalities, E and H, which is edema and hemorrhage, goes up on age 85 up to a level where it doesn't make sense benefit risk ratio. So 85 and up.
After the age of 85.
85,
okay.
yeah. Now, will people do it? They might. But our clinic at 85, in the trials, it was 85. So we try to stick to what the clinical phase 3 trials did. That's all we can really do right now. Is at the moment, we've only got these few trials that have been out there. The drug, when it comes to market, you try to mirror to a degree what the trials did. So we tell patients, we instruct them. These drugs are partially effective. 27 to 35, maybe as high as 40% of the patients that were on these trials had a stabilization or a decrease in the slope of their change over time, over a 2-year trial. They were not getting better. They didn't power for that. They were stable, or they showed some decline in the rate of the slope before they came into the trial over time.
This was in the second generation, or this has basically been consistent with every?
These are both trials, both trials. Yeah, both trials.
Okay.
They're in first generation medicine, both of these. So that being said, when I talk to patients about these drugs, they say, well, 35, 40%, I don't want to do that. Well, if we don't do anything, it's 100%. I'm telling you Alzheimer's today, and I'm very agree with this. We're just about darn sure that we know where we're heading. Right. So, people, even the function of getting up and walking to the bathroom on your own and getting your clothes on in the morning is a big deal. You might have bad memory, but if all that's still intact, that's really good. When you lose that, which is what happens in end-stage Alzheimer's, it becomes a real burden.
It's a gigantic burden.
Yeah, you're right.
Right.
I mean, 13 million people a year provide, care at no cost, which is family members basically in this country every year to patients with Alzheimer's. It's costing us $500 billion a year to care for Alzheimer's patients right now. $409 billion a year.
And that's one thing I didn't get a chance to
It's going to go up to $1 trillion a year in 2050, right?
Wow.
So it's going up. So again, prevention, right? Best we can, or reduction in risk. So as we treat these patients, we talk about that. So I say 40% is pretty good. But my goal when I treat these patients is, let's keep you on the steady. We got a good chance of that. And guess what? There's a ton of stuff in the pipeline right now. And the next best thing comes out, we're going to hop you to that. Next best thing, we're going to hop you to that. And if you're at the level you are now, though it's not perfect, in 15 years from now, we won the game. I'm not going to cure you, but my goal is to boom, boom. I did that with MS for 25 years. That's why I kind of learned that paradigm. When I started in MS 30 years ago, we had no drugs for MS. And now it's a chronic disease. My patients are in their 70s now with MS.
Wow.
Before, it was the number one cause of disability in women aged 35 and 40.
So slow it down, wait for the next best thing, essentially.
Pop you on that one, and pop you on that one.
And so let's unpack that a little bit. So nobody over the age of 85. You mentioned
in my clinic, there are people that might do it, but I don't do it.
And based on the studies, you mentioned 35. I heard the number that you said 35 to 40%. Is it 35 to 40%?
Yeah, I think I want to say in the one brand trial it was 27%. The other brand trial got 35%. When I looked at all the variables in those two trials, I use the number around 40%.
40%
efficacy and either slowing down or leveling off.
Okay, slowing down. And then what is the percentage?
And then risk of side effects.
ARIA, right.
Yeah, so ARIA, and that's where the APOE comes in. Mm-hmm. So if you're double 4, you've got, if you're double 4, we don't put you on the drug. Because the double 4 in the trials, they had the highest risk of edema and hemorrhage in the trials. So if you're 3-4, you've got about a instead of a 3 to 6% risk of a symptomatic ARIA. So symptomatic
3
means
to 6. Okay.
So 3 to 6. So we will during the first year of treatment, you'll be getting 3 MRIs, and the MRIs are surveillance MRIs by a protocol to look for ARIA E or H. It's the amyloid-related imaging abnormality, edema, or swelling. We'll see it, and I do see it. We see it. I'm seeing it probably. What they said in the trial is probably up to 30% of patients we're seeing ARIA. But it's part of we're learning now it's part of treatment with these drugs. People were freaky about it in the beginning, but now we're comfortable with it. We see it. We know about the degree how it should look and how much it should be and how much it shouldn't be. And we talk to the patient. We got a little ARIA going on here. Let's hold back a month, and we'll re-challenge.
Well,
so that's the art of it.
As a corollary to that, my understanding, at least with the study that came out, the first one that came out in 2021, is there was no necessarily improvement in clinical outcome. However, there seemed to be a slowing down of the symptoms like you're talking about. And as far as the risk of ARIA, even though you saw a greater incidence of swelling, you saw a greater incidence of hemorrhage, there was no change in clinical outcome. Is that
We speak into the first generation of medicine was aducanumab, which is Aduhelm.
which is no longer
They took it off.
Aduhelm came off. What happened there, unfortunately, was that we weren't prepared to understand the risk going in, and the patients. I mean, admittedly, I had pretty serious outcomes with a couple of my patients. We were putting patients on drug, not understanding fully the potential risk, and so we learned. It's just how medicine is, and so the newer drugs, I think they probably don't have any much of a difference profile in the first generation, but we know how to select better, and we're smarter in understanding the risk from side effects. Yeah. So that being said, we understand ARIA, RAE that's asymptomatic. Symptomatic ARIA, I've been blessed not to see it at this point, but it's not a matter of when, it's a matter of when.
Right.
We'll see that. But patients know going in, and you'll do the same to your patients, going into these things wide-eyed, eyes wide open. We have to understand the risks are there. They're small, but this is the brain. We're not talking about you're going to get a rash on your knee.
Right.
You're going to have a stroke. You're going to have a hemorrhage. You're going to have a grand mal seizure. This is not small stuff. So
right.
We got to be very, very selective. And I think as you all do the same thing, you really should be sure you're seeing somebody that deals with memory disorders, whatever neurologist you see, that understands these medications and risks.
It's just
very
so
key.
true,
It's so
Jim.
key.
And we see this all the time. Is I think that we call it practicing in 3 dimensions, right? And so you see, I think, unfortunately, or something, not all of them, but you'll see some of these different chains going up, maybe getting in the space of functional medicine or getting in the space of hormones or whatever it happens to be. And so there's this sort of, hey, if this is low, hey, we replace it. Or if you have these 5 or 6 symptoms, this means this, and then we give you this. And the reality, let me just use like testosterone as an example. There seems to be a lot of testosterone clinics going up, not just in Florida, but throughout the country. And we know that men are walking around with low testosterones. It's not all related to the fact that you've got this exponential increase in metabolic syndrome since the 1970s, the introduction of high fructose corn syrup. There's some other epidemiologic factors at play. And if we replace it, there are a lot of lifestyle things that can improve. What it doesn't mean is that if your testosterone is low, you just willy-nilly put the patient on testosterone. And it's like there's so many different things that you need to consider and need to look at. As a case in point, I had a 50-some-odd-year-old gentleman come into my clinic, and he, kind of your standard American, had worked really hard, and he had some, dyslipidemia, some hypertension, some obstructive sleep apnea, fatigue, low energy, low libido, some mild erectile dysfunction. He was low testosterone. And so he had gone to an outside clinic, and they asked him all the questions, and they drew his blood. And before they even checked his blood, said, hey, you need to be on testosterone. We'll give you the shot today. And, and so when I looked at him, he had basically undiagnosed polycythemia, meaning for the audience, that means his blood count, his hemoglobin, his hematocrit were abnormally high, and we had no explanation.
Give him testosterone.
Correct. We're going to exacerbate that. And so really, really, really would have been problematic. And I use that as an illustration. I think that we are passionate about the longevity space. We're passionate about medicine. We're passionate about prevention, functional medicine. But I think that in a lot of these places, you need a high-touch physician in these places that understands how to practice in 3 dimensions. And I think that's what you're
say. Yeah, I didn't say
on
my level, but on your level as well. I was in that space for almost 5 years, and we dealt with the same thing. So I tell people this: if you go into any of those centers, and there isn't a director or a medical physician that's on staff in there, then I would certainly take a second look, because these are just factories. You don't need to, as you said, there's not enough regulation yet. I think it's coming, because they're going to find that there's going to be some potential downside from this, from people getting hurt by just walking in these places and getting things and not being monitored correctly.
Sure.
So these we need to be very, very critical of that. And so who's man on the ship? What are the protocols? Understanding protocols. Do you have physicians overseeing things? And those are all questions patients should be asking when they go there.
A trillion percent. Last thing, and thank you so much for the clarification. One thing that I wanted to mention, it is interesting, the amyloid-beta 42, the tau protein deposition, and even the APOE4 subtypes of the APOE gene, all related to of course, the amyloid-beta plaque and the tau protein are related to disrupted or abnormal insulin signaling at the insulin receptor within the neuron. And then, as we know, the APOE4 can actually disrupt insulin receptor signaling. It can actually get in the way of the insulin receptor moving out of the lysosome, and it actually can be disruptive as far as allowing that insulin receptor to form a scaffolding on the plasma membrane of the neuron. So all of this, again, is related to insulin resistance, and again underscores the point and the importance of identifying and optimizing metabolic health at an early age. And so, this is especially when we're talking about prevention. Last question that I have for you. This is something that we're also very passionate about. We have integrated here recently with a group called Global Apheresis here at ARIA, headed up by, speaking of medical director, Dr. Kiproff, who's one of the founders. He's a pathologist out of Harvard, one of the founders of our, I don't remember the exact acronym, but essentially the American Plasma Pheresis Foundation. Your thoughts on therapeutic plasma exchange and the AMBAR study in particular, which I have right here. And I've looked over it a couple of times, but I want to hear what your opinion is.
So I'm going to say I'm definitely knowledgeable of the study. I know there's like 230 some patients that were in the trial. They took these patients, they plasmapheresed, they placed in their an exogenous albumin protein, and thought they were exchanging the bad protein for the good protein in the brain. Now there were some trends, I know, in the trial seen on outcomes on cognitive decline, cognitive change over time. And again, I think on all of these types of things, there's utility for all these treatments. There really is. I think that there's obviously more work to do in that process. I think there really is. I've not had any experience with it to date, and I think that your center is going to begin doing some of that here. I think that we should, we've got to look at all of it.
Yeah, we're and we're excited. What kind of caught my attention, just being sort of passionate about the longevity space. Really, we get patients that send us information, and I've got a couple of patients. It's like I just by reading what they send me, I keep up with the literature. Before the AMBAR trial, or actually after the AMBAR trial, Dr. Kiproff actually wasn't involved in the AMBAR trial, but the trial that he was involved in was a study called the Kiproff Convoy trial. And the Convoys are a husband and wife group team of scientists out of Cal Berkeley. And they were showing about 20 years ago with mice that if you took an old mouse and transfused it with a younger mouse's blood, that the old mouse would have a stoppage or even a reduction in biological aging. And what they found is that it wasn't so much the transfusion as much as it was actually diluting the plasma. And they got to the point where if they did therapeutic plasma exchange, you'd get the same results. So Dr. Kiproff came along and said, hey, let's try to translate this into human data. And the translational paper came out in 2022, and they were able to basically show all of these biological markers of aging essentially reversed. And what I thought was interesting is a couple of things. And Felice and I have kind of done anecdotal work and kind of looking at some of our patients that tend to have these, leaky gut or, various types of things like mast cell activation syndrome and some of these things that nobody can seem to find a solution for. One of the things that they saw in the study is as we age, there tends to be an elevated, ever-increasing neutrophil to lymphocyte ratio. And every patient in their study, they restored that ratio, or that ratio reduced. Tends to be an increased Th17 to T regulatory ratio. In every patient study, that ratio reduced. Th1 to Th2 ratio improved. Appropriate restoration of the CD4 to CD8 ratio. Tumor necrosis factor alpha, your classic markers of inflammation. Something called a senescence-associated secretory phenotype, which is reflective of autophagy, which is basically when we fast or when we're healthy, we undergo autophagy, which is the recycling of bad parts of dead cells and taking those parts of the cell that still work and recycling that into newer and better cells. We call that autophagy. So senescence-associated secretory phenotype is associated with impaired autophagy. Well, they showed a reduction in the senescence-associated secretory phenotype. So you combine that data with the AMBAR protocol, which essentially showed, like you said, with the monoclonal antibodies, it was a kind of a negative study. So it showed a 52% less decline in functionality and a 66% less decline in cognitive dysfunction. So it was, it was basically keeping patients at bay, similar to the monoclonal antibodies. And I think that it's when you can look at that data and you understand it, I think it's really interesting. And taking a step back, I can remember, my father's a nephrologist, so I can remember learning about things like, as a little guy, like TTP and like Goodpasture syndrome and basement membrane antibody deposition, all these things, and they would use plasma. I can remember being like 10 years old and being like, is that a dialysis machine or is that plasmapheresis, And so the thing of it is that we always thought of it as like, okay, we're removing bad things from the body, whereas over the last 30 years or so, there seem to be these immunomodulatory effects, and now we're actually seeing, hey, there might be some actual real longevity signals coming out of these different therapies. So like you said, I think if you look at the AMBAR study, very, very positive, a lot of really, really cool anecdotal studies, a lot of work to be done here in the future. But I think the neat thing about this is that there's a real frontier, and I think there's a really, really cool, we're certainly going to have a lot of opportunity based on the epidemiology, based on the metabolic dysfunction of our population in the United States and the West at large. But where there are great problems, there's always great opportunity. And so we're thankful for you being here and just, having been in practice here for the better part of 30 years. And
it's a great partnership. Like you said, it's all levels. We got Western, we got functional, so we have all these pieces that we're pulling together to make the patient better.
Absolutely, absolutely. Last thing I want to talk about, because I know you're very passionate about this. I know you and I have talked a lot about this. ARIA, and I'm very passionate. I spent 8 years active duty. I spent as a naval officer. Out of those 8 years, I spent 2 years active duty with the Marine Corps, and we have a charity here in the area called Hooks of Hope, where we work with specifically, most of the time, combat veterans, and we work with combat veterans. We do a week of or a weekend of fishing, but specifically, we bring in a clinical psychologist, we'll bring in a functional medicine doctor, we'll bring in a pastor, and we try to make lasting impact in those combat vets and try to affect real change. And so we're super excited about that. And I know you've done a lot of work with the SEAL Museum and working with the SEALs and all those kinds of things. So talk a little bit about that, and let's do a plug for that as well.
Yeah. So thank you for your service.
Thank you for saying that.
I appreciate every veteran that raised their hand. I've been involved in the Navy SEAL Museum in Fort Pierce, Florida since 2012. I've been chairman of the board for the last 2 years. I'm going to take on my third term coming up now nationally. So we now have a museum in Fort Pierce and a museum in San Diego. But a museum legacy piece is a small piece of what we do. We have the legacy and heritage of the Navy Frogman, if you will. We also have Trident Charities, which is basically our canine program, which we provide canine dogs to certain vets, SEALs. We have a legacy program. We also have the scholarship program. Our scholarships are different for us. It's for kids kindergarten through 12. It's not college. So we're treating these young guys going to battle, and some of them, who don't come make it back or have a severe disability. We're getting the kids. The kids are getting to college, school in K and 12. Direct family services, and we also have 2 Trident houses. So these are 2 houses in the area here where guys get off deployment, they get their family, we stock the house, they get the boat, and they get privacy, get a week or 2 weeks with their family coming off of a deployment. It's not easy to turn the switch off. They come home and get to hang out with their family, be with them. So they're full both times year round. And currently, we're sort of expanding our footprint to really create a cultural shift in how our generational, both our young, current, and older generations are thinking about their country, patriotism, service above self, good citizenship, accountability, all these things. So we're developing those programs now. That's really sort of our push, is to really how can we get anyone to serve, and then it doesn't mean serve in the military, but serve to something that's greater than yourself.
What a great,
And we're really working on that hard right now. So
what a great charity. I think that it's funny. We just came off this weekend, and it was so awesome. We had so many cool guys. On Saturday I was on the we had 4 boats, and we split the guys up. And one of the guys that was on the boat, we had 2 everybody was super cool. One of the guys he was still active, and he's a master gunnery sergeant with Force Recon. He went in 2000, so he's still active. So you want to talk about a guy that 2000 to 2028 hasn't ducked the tough times. So you're thinking about 9/11, you're thinking about Afghanistan, Iraq, back to Afghanistan, you're thinking about ISIS, all of the places that Marine Force Recon have been. And, he and I started talking, and what dawned on me, and he's an E9, incredibly intelligent. What dawned on me is how technical, and his understanding of the way that Force Recon integrated, his understanding of the differences between MARSOC and Force Recon, the technical aspects of close quarters combat, jumping, shooting, diving. And it just dawned on me that if you don't have in your civilization, particularly in a civilization that, or a country that values freedom, okay, and values equality under the law, if you don't have men that are willing to study war and be really good at it, that civilization is doomed to failure. So, and they come back with a very, very unique set of problems from both a psychological, spiritual, and medical side that I think we're starting to learn more about, and we're starting to kind of try to understand, hey, what is this going to look like when they get out? So you might have a kid who's 20 years old who enlists, who's a good athlete, who's, very high aptitude. You might say, okay, he's going to go bread and butter infantry, and then maybe he'll go to a Ranger battalion. Maybe eventually he'll try to get into SF or Delta or whatever. That's his career trajectory. I think we need to do a better job in the medical community. When that person gets out, what is their relationship like with their family? What is their relationship like? They've gone from this incredible, all these experiences to now they're in the civilian sector. It's not as exciting. The corporate world, these things.
That transition period is a big deal.
We need to be cognizant of this. Traumatic brain injury. I'm so excited about potentially looking at therapeutic plasma exchange in the setting of traumatic brain injury. If it helps with Alzheimer's, how much more so with traumatic brain injury, and heading this off at the pass. Hormonal deficiencies, metabolic syndrome, insulin resistance, cardiovascular disease. So, I'm so excited about it, so passionate about this. I think we need to get together. I think I'm on the board with Hooks. You're on the board. I think we need to get together.
We all should these VSOs. We should be working together.
That's right.
On all of this. We just real quickly. We're doing some newer research looking at the contussive, like the football injury that they're getting in the SEAL teams and guys of the special forces, and we're learning that the repetitive firing of rounds. These guys shoot millions of rounds of bullets of the forces going to the eye, into the brain, is creating gliosis and scarring. That's creating some of the components of the cognitive changes we're seeing in the brain. Wow. We're actually finding that we're getting the repercussive force from a round going through the eye into the brain. And you fire hundreds of thousands of rounds that these guys do. You're repetitively shooting into the head. With that force.
And I think the overwhelming majority of these guys, if they haven't had, an acute trauma where they lost consciousness or had a brain bleed, if they haven't had that, certainly we look at what we call secondary TBI, right, or traumatic brain injury, where it wasn't that big knockout from Sonny Liston. It was just having to fight Joe Frazier over and over
blowing doors
and over
every night,
again, the repetitive things. And so we're looking at that aspect of things. And so what you're saying makes a tremendous amount of sense. I think that, again, if I were, the way that I want to understand this is, okay, we now have a real strong idea that this is going to happen long term. What do we do when you're 45 and you get out? What are things that we can do right now to help that brain health?
Well, doing their end too, right? So doing their end. So you said the special forces guys and all the armed forces. It's a special group, and I say special in a negative way, but they're they're all most of them see in combat. Their training cycles are much more intense, and their training's much more intense. And they've got a lot more exposure. So those are high risk group.
Yeah.
We've got to be very sensitive to. So that's a very high risk group.
You know, and I'll close with one last thing. You know, we've got, if our audience is interested, the AMBAR protocol. You know, Dr. Schaefer, tell us the name of the specific charity.
Oh well, it's the UDT Navy SEAL Museum. You know, and you can go to website, type in Navy SEAL Museum. If anyone doesn't know, it's right here in Fort Pierce. It's been here for 40 years. On the beach where that museum sits is where the men that went to Normandy trained. So those young guys that went to Normandy, and 52% of them were killed that morning, trained right here in Fort Pierce, and that's where that museum sits.
52%, and if you think about that number, you know, I think every American, and again, my son, since the time he was little, we always hang a POW, you know, MIA flag. We have an American flag, and I always tell him, I say, hey, whenever we do our 4th of July or whatever we do, we enjoy these things, but we enjoy them at 95%. There's always a 5% that thinks about these things and these guys that did these incredible things. And the bottom line is you know, that was Normandy is one of those things it's actually hard to fathom. You've
got to get to Normandy sometime. If you've been there, I have a special trip for you if you want to do it.
Absolutely. Oh, okay. I'll take it. We have actually another source beyond the scope of this of the
We'll
the
tell you
talk.
after.
Yeah, I would love it.
But you know, Jim, we highly appreciate it.
I appreciate being here. It's great.
We're so thankful.
I learn every time I talk to this guy. He's like, you know, I love
5 times more with us, and
both of you. Thank
we're
you
so
so much.
thankful. You're a great American, and let's do this again. We appreciate it.
You bet, my friend.
Thank you so much.